if you think, what is the life of a normal child who is not sick? It is playing.
Yes.
It is going to school.
Yes.
Having friends. All the things that the child would be doing at home. So a child who is in hospital, even if it's only for a week, would be missing out on so many things.
Correct.
There are only painful and scary things happening around.
Correct.
And a child needs to play. It's part of the development of a child. A child needs to read, to study. And if this is hampered by an illness that is taking longer, is not allowing the child to go to school, then they may have worries.
Hi, everybody, and welcome everyone to another episode of the podcast Living Well. I am Smriti Khanna, and today I am calling upon in our podcast, Dr. Veronique Dinand, and I'm going to ask her if she can speak a little bit about herself.
Yes, a pleasure. So I am a pediatrician, basically, by training. I trained in France, in Paris, and I moved to India in 1996, in Delhi. I was in Delhi for quite a number of years. And I worked basically in community pediatrics in a slum area, then moved on to doing a PhD in pediatric oncology from AIMS, New Delhi. And then I worked in clinical research in pediatric oncology for quite a number of years. And then I decided to shift to palliative care. And that's when, after starting palliative care there in Delhi, in the hospital where I was working, 2 years later, I decided to move to Mumbai to establish a palliative care department in a large hospital for children, a pediatric hospital, which is a public hospital, 5 years ago in 2019.
And that is where I met you.
That's right.
That's where I met you just a few months or a couple of months, I think, after you decided to start it. And we hit it off, and I asked if I could work with you. And then that was the beginning of a wonderful chapter of 4 years in my life, where I worked along with some talented people, some warm-hearted people, and skilled professionals, and we established a lovely unit that provides pediatric palliative care.
Mm-hmm. Yes,
that was
wonderful to have you on the team because that's a great adventure.
That was a great adventure that we went on,
because actually we don't have any such established department in a children's hospital anywhere in India.
Yeah. This was, I think, there are just a few established pediatric palliative care units. There's one in Hyderabad, and then there is one in Mumbai. And I think newer are coming up and will come up soon. But it was, as you said, it was an adventure just starting it. But what I'm curious about is, what made you, I know one thing that I had asked you right from the beginning is what made you make the move from France to India? And that's what I'm first curious about to know.
I have to say that it's a dream. It's difficult maybe to portray, to understand it, but it's a childhood dream or early teenager's dream that I wanted very clearly to be a doctor, to be a pediatrician, and to work in India.
Wow.
That was very clear in my mind, and I pursued that. There was no doctor in my family, lots of engineers, and my great-grandfather was a doctor, and after that there was a gap.
Lots of siblings, no? In your
Lots
family.
of siblings, yes. There are 8 of us. And then I went in medical school. Then we have a tough exam to be able to specialize, and I was able to get through and choose pediatrics because I only wanted to do pediatrics because
wow,
it was a dream.
So that was one unconventional path from France to India, and then there was another unconventional path, because if I think about it, I can I can count the number of pediatric palliative care physicians on one hand that I know, probably at least in India. And you are one of them. You are one of the first pediatric palliative care physicians that I know. So what was this transition like? Pediatric oncology, which is cancer which is childhood cancer, is something a lot of people pursue. But the shift from pediatric oncology to pediatric palliative care, what was that like?
It was a very natural shift. When you deal with children who are battling against cancer, you encounter a lot of emotional suffering as well as physical suffering, which at times I felt was unmet, especially the emotional burden I could see in the eyes of parents who at times had a lot of questions that were either unsaid or unanswered. And I felt that there is a need to improve a lot in the field of communication and a lot of things that are maybe it's on the side. It's not the direct treatment of cancer. It's not chemotherapy or radiation or surgery, but making the child comfortable with child-friendly activities within the hospital, and trying to help as much as possible for schooling, meaning for the child not to be to lose too much in all the academic. This is an aspect that is very important. And treating the pain, and the pain, which of course physical pain, but also other kinds of pains I could see in the eyes of those children. So that's when I felt that, coming from a children's cancer background, I felt many other children who are not suffering from cancer also have lifelong chronic illnesses. And it would need this type of holistic approach to care that will help them throughout the treatment that they are undergoing. And palliative care for children would be not only for oncology, not only for cancer, but for a large number of other conditions.
In fact, because I also know this, that or we have also seen this, that a lot of children who have other life limiting illness will end up living longer, will be more dependent on their families, will need a lot more additional care and support than if you think about it in terms of lifespan or the time that the child spends with the illness. With cancer, you know that you have a very clear-cut answer of which way it goes. You have either cure or you have not cured. But with other life-limiting illnesses, those will go on for months, maybe years, and there is no end point of complete improvement or a complete kind of cure, isn't there?
That's right. So that's how the focus that we have in palliative care on the quality of life is very important, not only for the child, but for the whole family, the parents, the siblings, the parents who have this maybe burden. At times, it's mostly the mother who has to look after a child who is possibly, in some cases, dependent in neurological illnesses. Both the parents maybe have to come in and out of the hospital very often. The father is unable to work, and the siblings maybe may have to drop out from school, or siblings don't have the same attention that the sick child is receiving from the parents. And they may at times wish that they were the one who is sick, because then my parents would look after me.
Wow.
So we also address that aspect in children who have chronic illnesses or serious illnesses.
So, I'm thinking about one child that we had seen together, this 13-year-old boy who was absolutely okay beforehand. And then COVID happened and he had a COVID-related heart problem. And I remember this. This was we had been seeing him for a few months because of the COVID related heart problem. He didn't have enough oxygen that reached his brain, and so he became paralyzed. He wasn't able to communicate or talk as he was before. And I remember this one point where his mom brought him uh, to our OPD, and she said, when is he going to get better? And we had to tell her that he's not going to get better. This is how he is now, is how he is going to be. That moment was so striking. You could see the reality dawn on her face, and you could see a lot, so much trying to. I could literally see her trying to process. Okay, this is how things are going to be like for the next few months, for the next few years, for the rest of my life. I'm going to have to be taking care of this child.
So that shows that actually it takes time to process, because we told them in the hospital already that he was going to be like this, and the father was very very clear, saying we'll do whatever is needed for him, we'll look after him, we have family support. Later on, probably the mother was like, did not understand the consequences that would have on her life. We go on a regular basis for home visits, and all over the years we have been doing that very regularly, and from time to time he needs to be admitted in the hospital to help for the feeding and things like that. So we continue to be very close to them. This mom doesn't leave the bedside because he's totally bedridden, and it's as if her life is no longer,
is that boy.
She doesn't leave. She doesn't come out of the room. They live in a troll. So it's a single room, and she doesn't come out. She doesn't see the sun, only to take a taxi to bring him to the hospital. And whenever she comes, we also, to her and her husband, they need a lot of also emotional support, to just listen to them. How is your day-to-day life? What can we do to make it better, to give you a little bit of rest, of respite
in the day?
Because it's been 4 years.
It's been 4 years
now he's heavy, he's bigger.
Yes.
He's 16 years old. And yes,
it's tough.
It's tough.
I'm just wondering, for a family like this, if there were no palliative care, if there were no team of doctors and nurses, if there was no home care that we could actually go and see this child, maybe change his feeding tube, every couple of months, what would it be like for a family like that to navigate a health system? I mean, they would probably come to the same hospital, they would have gone through the same things, it would have been the same admission, discharge, but the after that and the years after that, what would have it been like for them if there were no palliative care?
They would have been in and out. The only recourse would have been a hospital. So they would rush to the hospital much more often, be admitted, like whenever he starts coughing and having fever, and we go and check, and he may have a pneumonia, he may need nebulization, like with a mask, some medicines that we can give. So we give him antibiotic at home through the feeding tube, because there is we can manage without injections and all that. So it's somehow much more comfortable. The mother has been properly trained for physiotherapy to help him to take out all the secretions that are there and disturbing. And then the phone calls, the fact that there is always someone to advise on the phone and to say, don't worry, it can wait for tomorrow, we are going to come and see.
Yeah.
So we go every 2 weeks to change the feeding tube. And whenever there is a need to come to the hospital to see a particular specialist, to see whatever, the surgeon who has put the feeding tube, finally we put it in directly in the stomach. That's much easier for the mother. She can feed him faster. So there is less number of
hospital visits.
That's right. Hospital visits, hospital admissions. And the father at least can go to work.
Yeah.
Because if the child is admitted in the hospital, mom stays with the child and dad has to stay outside the hospital to
get things and all of that.
To go run around, get medicines and all that. And nobody is there to look after the other brother who goes to college. So, and then all the emotional aspect of knowing that you are not alone, basically. That the team is there with you, for you. And it's a bit like a family. When they come, they know they can talk to anyone, because now we are a large team. We are 13 of us. And more additions to the team, even though they are more attached to the first people who were there on the team at the time of the initial illness. When it was a dramatic event that happened. He was a normal child. And no, I say he's 16 now. No, he's younger than that. He was a totally normal child. And then
I think he was 11 when he had
this event. So he had breathing,
issues.
The heart breathing issues, and then the heart stopped and he needed to have a...
And this team that helps take care of this child. I'm always struck by, whenever I visit the team, I'm always struck by how amazing it is to actually have a large team taking care of palliative care in a public hospital. Because I know I came to you and I decided to work with you because I was interested in pediatric palliative care, but I think I stayed for the team. I stayed because it was a wonderful working atmosphere. It was so democratic, which is not something that you see in healthcare teams overall in India. There was so much to learn from each other, and I think at the end of it, I think we were a 6-member team for at least about 1.5 or 2 years, and then we started adding people, and some people left. But that first 1.5 year, which was like the formative times of our team, and how we were just able to gel together, I think that was so wonderful. Can you tell me a little bit about what made you want to make a team like that? We were doctors, we were nurses, we were psychologists, psychosocial workers. Not many teams are like that, 2 doctors, 2 nurses, 2 psychosocial workers and counselors. Can you tell me a little bit about building that?
By definition, palliative care is a multidisciplinary team approach. So that was very clear on my mind, that when I was offered when I searched for, I approached the medical director saying that I would like to start palliative care in this hospital, because it's the largest children's hospital in Mumbai, and it's a charitable trust-run public hospital. I need a team. That was very clear from the beginning. So, and I have to say, because each one of us is able to approach different aspects of the needs of the child and the family. And there is a lot of course, medical issues, and there are lots of nursing issues, and a lot of psychosocial issues, which each one with their own skills is able to address. And we all learn also from the others on the team how to grow in that care, that aspect of the care which they master so well. So I have to say that coming from France, I have that idea of team and the importance of other healthcare professions. It's not that the doctors are superior to nurses or to psychologists. We each are complementary in our work. So that non-hierarchical approach was fundamental for me. And that's how I built the unit. And that's how it keeps on working. So every Every week we have a meeting of the whole team when we can express and the whatever we want about the families we are meeting, and everyone has to speak because that's how also and each one builds up confidence. I see it with the new additions to the team and the younger people. They find it a bit surprising, but they learn also from the others that yes, you please also, you have something to bring to the team. Each one of us are learning from one another.
And I think that from what I remember, because it was so interesting, because if I know that one member of the team will focus on the child, I know that the other member of the team will focus on the mom or the dad, and one member will speak about coping with illness, and another member will speak about very practical things. So if our psychologist is going to speak with the family about coping with the illness, it's just emotional, psychological coping. Our nurse is going to sit down with them and tell them that this is how you take care of a bed sore, this is how you do her feeding, this is how you make sure that she is well nourished or well moisturized or any of those things. And so at the end of it, if you have a smooth functioning team, it just works like a well-oiled machine. Every team member just intuitively picks up something that they need to work on. And then I think that with time, you had the brilliant idea of getting some additional members which are not conventional members of healthcare teams, I would say. So what was so interesting is that we have a clown therapist on the team.
That's right.
We have a book and toy librarian, somebody who keeps who reads to children, who knows which toys to play with or to give to which child. We also have arts therapy that we have started. We've started music therapy also at the same time. Can you tell me a little bit about incorporating all these things into a palliative care unit?
Into a palliative care unit and to a children's hospital, I would say.
Yes.
Because we felt that this was needed not only for children who are benefiting from palliative care, but from all the children admitted in the hospital.
Yes.
To make them, to make their days or their weeks or their months in the hospital more, less scary, more pleasant, more childlike. So the children's book and toy librarian goes to read and to provide coloring material to all the kids who need it anywhere in the hospital, in all the wards, and with special emphasis on children in the ICUs who are conscious, who are not on a ventilator, who are able to do something. This is so important for them to stop, meaning to divert their attention from all these machines that are making sound, all those scary doctors and nurses who are always pricking me, and all those tubes everywhere. So that is a very the book and toy librarian, the clown therapist also comes. She comes on once a week, and that day you can see children who have been in the hospital for more than a week are really looking forward to that day, because she goes to all the wards, all the ICUs,
and not only
and
the children
corridors and the parents.
She works on the parents
and
she works on the nurses,
doctors,
on the doctors at rounds.
So at times you may have, for example, a call from a doctor who is trying to do a very difficult procedure. Like in the cath lab, that is a cardiologist who is doing something to go up to the heart of the child, and the child there is no need for anesthesia.
Correct.
For general anesthesia, but a child who is very apprehensive and who doesn't want to have the first prick, then it happened that he said, okay, Monica, please, can you come to just relax to help this child relax, and let us start. Once we start, it's okay. And it was a wonderful experience, both for the child, the family, the doctors, and for the clown therapist herself. She felt that really we use a lot the clown therapist and the book and toy librarian for when a child needs to be pricked,
Hmm.
those children who have frequent pricks, and we can help to divert their mind. Of course, we apply a cream that will be
Numbing
anesthetic.
cream.
Yes, numbing cream so that the child would not feel. But for the fear of the needle prick,
Just
then-
seeing the needle scares them so much, and
Yes.
then they will start.
so
crying.
diversion is very helpful.
And if one child cries, then another will cry. So just to calm everything.
Yes. So music therapy, we have really focused on children who are on palliative care, who may
Okay.
not be able to relate or to communicate,
Hmm.
maybe because they have some problem in the brain, some surgery has been done,
Hmm.
or some of them maybe even in coma. And
Okay.
the music therapy can help a lot for relaxation, not only of the parents, but to have some kind of communication with the child.
Mhm.
And we have responses on the part of the child or other children also who are able to communicate. It's also very soothing. So all these child life activities are very important. And when the typical healthcare professionals are seeing the children, we often have to send a message or give a call saying, please come and see this child, because that would be very helpful.
What do you say if to people who will ask why? I mean, a hospital is where somebody comes to get better. It's a very business-like place. It's quick in, quick out, as much as you can. Just come in, take your medications, spend those 5 days, 7 days, 10 days, 1 month in hospital, go. What do you say to somebody who tells you, why have all these activities? Some may think it's frivolous, some may think it's you are just bringing down the tone of the hospital, of what a hospital should be, a serious place. What do you say to
Not
that?
at all. What are you saying? We are talking about children. So we are
Hmm.
talking about life. In the hospital, if you think, what is the life of a normal child who is not sick? It is playing,
Yes.
it is going to school,
Yes.
having friends, all the things that the child would be doing at home. So a child who is in hospital, even if it's only for a week, would be missing out on so many things.
Correct.
There are only painful and scary things happening around.
Correct.
And a child needs to play. It's part of the development of a child. A child needs to read, to study. And if this is hampered by an illness that is taking longer, is not
Yes.
allowing the child to go to school, then they may have worries. We have kids in 10th standard who just think, okay, I want to sit for my boards. Okay, we are here and we are going to help you to study. And we get volunteers who can come and help in the study, and also that encouragement, saying that you can do it. And we have so many children, teenagers, who have gone through the 10th boards. And so it's not frivolous. Parents absolutely acknowledge the fact that someone who brings coloring books and coloring whatever, sketch pens or crayons, is doing a great thing,
A great
favor.
service.
And doctors are the ones asking us, even when we get into the ICU, and they would say, where is the book and toy librarian? Can you please call him for this and that child?
Yeah.
Can they bring some toy? Can they bring?
Yeah. So it's quite interesting, because an ICU doctor has a ton of things on his mind or on her mind. She must be having about 100 things on the list, but she still will remember that this child needs a book to read, this child needs some crayons.
Yes.
That says so much about doctors also,
about the impact that we have had over the past 5 years, that they have seen that the quality of the life of children can improve greatly, and their stay, for example, in ICU, can be much more comfortable if these type of activities are offered. So another thing is that we have a room. We have been given a room which is actually all communicating, but it's like 4 small rooms communicating with each other, which are counseling rooms, but are mostly playrooms. So 2 playrooms with lots of toys, nice paintings on the walls, and absolutely child-friendly and relaxing atmosphere.
Yeah.
There is
Yeah.
no needle prick ever there. So children coming from the wards who are able to be brought on a wheelchair, on a stretcher, or even walking for some of them, will spend time there. And it's much easier to build a rapport with a child that who can start opening up and telling a little bit the difficulties they are facing. It's very natural.
And why have if you think of palliative care, I mean, we have been working in it for many years now, but I whenever I talk to someone I have met for the first time, or say someone in my family, about palliative care, there is always a lot of gloom and doom associated with it, and they're saying like, oh my god, children who are dying, oh my god, people who are dying, how can you see children who are dying on a daily basis? But in my 4 years of working in that room was such a wonderful atmosphere to work in. It's a beautiful office to work in, actually. I've never worked in any office like that. And also the kind of families and children that we saw, there it wasn't all gloom and doom, right?
Yes, we always give them hope. Even it's true that there is this misconception that palliative care is equal to end of life care. So end of life care, as we all know, is only one aspect of palliative care.
Yeah.
Palliative care starts at the time of initial, when we get to know that there is an illness that is a
There is
serious
problem.
illness, and all throughout the trajectory of the illness, which in some cases will be. It's true, we may get ready to lose the child, but and then we will provide support, emotional support, to the child, to the family after losing the child, also later on. And we keep on calling, and they come back, and we have bereavement support groups on a regular basis. But for the team also, we look after each other, in the sense that someone who has been closer to a family and to a child, to whom they may have, we get attached to the children.
We do.
And we all have kind of a void that is there when we lose a child, because we learn to empathize with the parents. So we have feelings. So the way we all look after each other and have moments of relaxation, that I have heard quite a few people from the hospital, from other departments, who say that whenever we pass by your room in the corridor, we hear so much laughter, and this is a palliative care department, and but this is true.
It is true,
because this is the way we relax, and the way we can go home without carrying
all that burden
of emotional burden of the families we have helped.
And I think the team has helped so much with that. Just helping share the burden, dissipating it, kind of just letting it go before, so that, as you said, when you go home, you are going home with a fresh mind. That's true. But we will get back to I want to ask you about the bereavement and care of a child who may not have too much time left, who may be towards the end of life. But before that, I also want to ask you a little bit about what your experience of palliative care has been in these last 5 years of seeing these children. Has it all been children who are very sick, not going to get better, or only passing towards their end of life, or has it been other types of children with other illnesses, or illnesses which there is an illness, but they are able to kind of be having a normal life,
from that,
recover or have a normal life?
Yes. So we've Out of more than 2,800 children and families we have looked after in the
Wow.
past 5 years,
Wow.
now 2,800, we have a large proportion, I would say maybe less than half, but of children who are what we consider, we are aiming at a cure
Okay.
of a serious illness. I'll take the example of a girl who had tuberculosis that was in the brain. That is what we call meningitis, tubercular meningitis. And that had affected her to such a degree, a 12-year-old girl, that she was unable to communicate, to sit, to of course, stand, walk, sit. She was just bedridden. She couldn't eat on her own. She was fed by a tube. And she was on regular medications. Medicines had been started. It was about a month already of those medicines. And then we were called to help the parents take care of her and preparing them for going home.
Okay.
And I remember the mother saying, how can I take her home? She can't do anything. She's not okay.
Yeah.
And that was true. She was not okay. We explained especially that there's a lot of nursing care that is needed for the hygiene, for prevention of pressure sores, having a special mattress. We helped the parents, provided everything, doing physiotherapy because she wouldn't move. So to make sure that her limbs would remain agile and not stiff, because we had the hope that in the future she would be able to walk, to sit and walk. And she had to be fed by tubes, so the mother had to learn. And we always encourage the father also to learn so that the mom can take some rest, especially at night. And then when they were ready for going home, and then we saw them on a regular basis when they would come back to the tubercular TB OPD. And then little by little, this girl came with. She opened the eyes, then she started sitting up and coming on a wheelchair, and then she started smiling, she started talking. Then 6 months later, she was able to stand, then she was able to walk, and 2 years later, she was going back to school. And it was such, you could see the parents every time taking a picture with us, and we saw the changes now. So we have children with all kinds of condition. Some, when you say they are not going to get better, that is true, for example, of a child with diabetes. Diabetes is a lifelong illness where the child needs to receive injections of insulin, checking the sugar level every day, several times a day, to see how much of insulin that is to be injected 3 times a week. 3 times a day. So it's a very we could say it's a burden. It's
a tough thing to go
thing.
through,
And
especially for a teenager who is rebelling against pinpricks and doesn't want to get injected 3 times in a day.
And it's difficult for the school. School timing. So some schools are scared and they don't want to take the responsibility. So then we have our book and toy librarian goes also to the schools to talk to the principal, to the teacher, like to do that link between the endocrinologists, that is the doctors who are treating the diabetes, and these people. And we have group support.
Support groups.
Sorry, I'm so sorry. So we take children that may be 4 or 5 who are at the same time admitted in the hospital, or larger support groups when they come from home and they see other children with diabetes with the same condition, and we do fun activities, and also they encourage each other in that sense. So
it's called Candy.
Candy, yes.
Candy is what it's called.
Because
we asked the kids what they wanted and they can't have candy, and so they called it group. Candy.
Yes. But we have other kind of illnesses with also support groups like that. So I lost the track of your question, actually.
So what I was asking about was children who may not necessarily have they have illnesses that impact their life, but it may not impact the longevity or the length of their life. It may
Okay.
impact the quality of their life
Yes.
to some extent. But what you said about the book and toy librarian actually going to the schools, that is such an important job, because um, uh, if a school is afraid of having a diabetic child in the school, I mean, that child is going to have diabetes for the rest of
Yes.
his or her
Or
life.
a child who is wheelchair bound
Huh.
because of some damage to the spinal cord or whichever
Yes.
neurological or
Yes.
muscle problem, then to try to see how things can be managed in the school,
Yeah.
then we need to go and see and help the parents and help the teachers to
So
integrate.
this
the
is
child.
integrate, like that is the, I think that is the important. So what I remember reading about palliative care a few years ago is that you kind of just help them along their journey, and then when we come from a medical background, especially doctors, we think about it only in terms of medical journey. So we think about it, we probably think about the children only when we see them in the hospital, so we don't think about their life outside the hospital, we don't think about their parents or their families life outside the hospital, we don't think about how the illness is impacting their school, their ability to travel, to do the things that they want to do. And what struck me about palliative care is that it says all of these things are important, all of these things are valid.
Very important.
They are important for a child to be able to live their life to the fullest, for an adult or a child, whoever it is that you are seeing. This is what actually made me want to work in it, because it gives you such a full worldview, isn't it?
Yes, and it's also looking at the child and helping the child and the parents not look at the limitations that the illness is imposing on them.
Yeah, yeah.
Not looking, even I am not this illness is not defining me. But what are my strengths? What can I do with those limitations? And we work and we develop those strengths and the positive aspect, which helps a lot, not just cope with the illness, but live life to the full with.
Irrespective
Yes.
of whatever else is going on.
That's right. And that's why getting to know the family dynamics and circumstances is very important for us.
Yeah.
When as much as possible, when we go for home visits, it is to assess what is the home setup, how many rooms are there, how the grandparents or in the joint family,
Who all helps them?
who can provide some respite to the caretaker,
To
or
mom or
also help and be trained by us.
Yeah. You spoke about bereavement, and you said you also spoke about bereavement support groups. Can you speak a little bit about what is this bereavement? What is it like to take care of a child who is nearing the end of his or her life, and what it means?
So it's a very difficult and delicate topic. A child who is nearing the end of life very often kind of knows it by intuition. And what we very commonly see is that parents, even doctors who are the primary doctors, the ones who are mostly treating the child, may not want the child to or may not want to have an open conversation with the child as far as the death is approaching.
Yes.
So that is always a difficult thing to tackle, and our senior counselors are really very very expert in that field of assessing from the parents what are the fears that they have, just assessing how much the child knows, and very often we are just having the link to help the parents realize that the child knows much more than they think,
yeah.
and that those open conversations are releasing a lot of anxiety
Mm.
and fear, and that enables the family and the child to have a very meaningful weeks or days before which are this end of life, that we can more or less have an idea when what matters most can happen. That maybe relatives or friends that the child would like to meet, that maybe places where the child may want to go, things that will be very meaningful for the child and very like rewarding for the family, who will remember that we have done the last wishes of the child. So this is, it sounds very difficult to talk about that.
Yeah, because uh, somebody listening to this conversation may want to ask, uh, what is the benefit in talking to a child about death? There is a lot of, if when we actually go to do it, we face so much resistance. Families don't want us to speak to children about death. The child's primary doctor may not want us to speak about death. They themselves will feel so scared or worried to talk about it. So why do it then?
So there is a lot of what to say. The child themselves understand something and are worried about something, which they need to be able to speak. And usually, what we use books. That death is everywhere. That can be the death explaining a book that explains how leaves fall from a tree, or how this little kitten or this little cat has a lifespan and dies, or a rabbit. And then reading that with the child will start talking about, oh, my grandfather died, and what was it like, and what do you think, where do you think he's, or things like that. So it's not coming to the child bluntly and directly and saying, you are going to die. No, it is exploring how much the child understands about their body, that the body maybe is getting weaker and weaker, sicker and sicker. And there is children understand that initially maybe they hope that okay, I have I have an illness, but I will go home
I will
soon.
get better.
Then I have a serious illness and I have to stay in the hospital. This Some children with this sickness get very sick. Some children with this sickness die.
Yeah.
I feel that I am getting very sick. This is a progress in the understanding of the child, and then I think that I may die of this illness, and I know the next step. I know that I'm going to die, and they go through that process, and we cannot leave them alone in that process, because especially children who are older, maybe teenagers, they know that this topic is very painful for my parents. They see their parents cry after going to talk to the doctors. They know something is wrong. I don't want to add to the pain, the suffering, or the sorrow of my parents. So I'm not going to talk to them. But talking to another person about the way I'm trying to protect my parents and not opening up about my fears is actually so liberating for the child, and liberating for the parents to know from that same person that actually this is what your child is thinking. Now, would you like to be more open about and to answer the questions? Because we will not answer those questions unless the questions of the child, unless the parents are okay for us to do so. And it may take time for the parents to reach the point when they say, okay, we can tell them.
So I think it's an extension, right, of when you say that going through the journey with them, or making the journey easier for them. If you can't change the journey, if you can't change, or rather, if you can't change the route that they have to go through, at least you can make the journey
more
easier. Make it
That's
more
right.
comfortable, make it. And this is something that even I have noticed, that when we speak with some children about death, there is a lot of calmness and peace that you see in them. after having spoken to them. It's almost like fears are allayed, questions are answered. They know what's happening and they're not afraid of it. And children aren't supposed to be there, no, like children aren't supposed to be able to solve problems like that. But a child who is sick sometimes gets the maturity that adults do.
You know, I remember the concern of a child was who is going to, what's going to happen to my toys, and the legacy that they can give. That okay, I want to give them to this to my sister, this to my brother, and that is who is going to look after my parents. And
Yeah.
all these questions, when the answer is given to them, that gives them a lot of peace, actually. And I remember this teenager who we had been looking after him from the time his cancer had come back, and he was undergoing treatment for the cancer. And unfortunately, after a year, that treatment, again, the disease came back. And then, yeah, we were on a regular basis in touch with them whenever they came to the cancer OPD. And then they went back to the village. They lived 3 hours away from the hospital.
Okay.
It's not that they were living in Mumbai, no, outside. They were like an hour from Panvel station. When he was very sick already, nearing the end of life, we actually lost him 1 week later. On the phone, we were constantly with them on the phone. The parents were crying and saying that he doesn't want to move from the bed. He's not doing anything. So we said, we'll go on a home visit, even though it's very far. So we always have some people on the team who have a special bond with a child. So that male nurse and that psychologist went to see him. We had prepared a huge card with photos of good moments that he had spent together with two of his friends who were also treated for blood cancer that had come back. It was a very cohesive group of 3 boys, and we had taken them to Gateway of India, to Chowpatty beach, and then we had got all the people on the team from doctors, nurses, psychologists, parents, and other children from the cancer ward, and from our team. And everybody who knew him had written some message.
Even the oncologists.
Even the oncologists, especially the oncologists, because most of the people that were attached to him, they knew for many years. And then they went there. He was unwilling to talk, whatever, just his two sisters and parents were around the bed and just crying, doing nothing, waiting for him to die. And once they said what they were bringing, they opened the huge card, and then his attention started being attracted to that. And then he sat up, and then he looked at everything, and it was a total change in his behavior for the next 1 week before he died. He was again happy of living to the full, because he said, I am not alone. All these people remember me and love me. And that really, and that gave so much courage, not only to him, but to his sisters, to his parents. So after that, we are very much in touch with them to help them start afresh, for the sisters to go to college and to go on with their life without forgetting his life and to celebrate his life. So that's what bereavement is about, is to help the relatives go on, first of all, cope with the loss, which is a terrible loss. And it takes the time it takes, many months, and that's normal. It's to normalize the fact that it's normal that you miss him, and it's normal that you cry. We never say don't cry. And we listen.
Wonderful.
We are here to listen to you, and we are here with you, journeying with you, and so that you can again recover the joy of living and the strength
Wonderful.
of living.
Yeah.
So we have, like, on Saturday, we had again just small groups
Huh.
of three parents,
Huh.
three groups of parents,
Huh.
mothers and some fathers also, of children we have lost in the hospital from different wards. They didn't know each other at all.
Okay.
But at the end of this session, where we have two senior psychologists, psychiatric social worker, and a few more on the team who are with the parents, and we help them express themselves. At the end of a 2-hour session, 2-3 hour session, the parents themselves have such bonding
Yeah.
with themselves,
Yeah.
and they get encouraged to tell other parents whom they know from the ward who have also not yet mastered the strength to come back
To come
to the
back.
hospital.
Because it's
That
difficult to come back
it's very
if you've
difficult.
lost a child.
It may be a year later on. Sometimes we do those bereavement circles in other places,
Yeah.
like in some maybe home-based or another NGO who gives us the premises of their
Yeah.
offices,
Mm.
so that they don't have to come to the hospital,
Mm.
but still they can benefit from this support.
Yeah.
And other parents to see how they are coping, and that helps them a lot in their grief.
That was a wonderful story, the one that you shared about this teenage boy's last week of life. And I think that when people hear, I mean, people rarely find, like, are able to listen to these stories at length. But when they always ask me, how do you find the courage to be able to work in a place where you have to do all these things? Uh, this is, like, the last question that I want to ask you, that what do you reply to something like that you do such heavy work, we do such heavy work, but what gives us the motivation to go on, the motivation to be cheerful and to turn up at work every day?
I would say it's a very, very rewarding specialty, because what to say, we see the impact that our work has on the life of maybe these distraught families.
Yeah.
We have the great satisfaction of easing pain,
Yeah.
pain in all its dimension, physical, emotional, spiritual, social pain. And we see parents who, over it may take the number of days it takes, parents who are very angry with accepting the illness, accepting the fact that it may not get better, or it may turn out to be a very bad outcome. Ultimately, all of them turn out like, I don't know, there is a shift in their
Yeah.
acceptance,
You can sense it.
and they are very grateful. And it's like the fact of telling them, you are not alone, we are here with you, is very rewarding. We never have defeat in our work. For a doctor who is looking at cure, the fact of losing a child, or the fact that there is no cure to this illness, is something that can be distressing. Meaning, it's at least frustrating, definitely.
Yeah.
But for us, there is no frustration.
It's thought of as failure, no?
There is no
Not being able
failure.
to cure a child. But
Yes.
I think what we try to say is that it's not failure, because
We help the child live to the full as much as possible, and the family cope with the illness. And this is very rewarding. Plus the fact that we really are a team and we support each other.
Yeah.
Whenever someone has to take a step back, because we see it on the face, one who comes from a difficult conversation with a family, or in the ICU, and we say, okay, sit down. How was it? You need a break, and just keep quiet. Now, no work for half an hour, for 1 hour, whatever. And then we check on each other once we go home, maybe in the evening, saying, how are you with this doing? Because sometimes we have to go back to the hospital on Sunday, and it's we look out for each other, and that is very important.
And I think the weekly meetings also help, where
Mm.
everybody gets to talk about it.
Mm.
That's what.
And we don't wait for the weekly meeting to
Not
talk about
always,
it.
yeah, yeah.
In small
Yeah.
groups, we will talk also if need be.
Yeah, I think that's what struck me also when I was working in the unit, that yes, it's heavy work, because seeing kids dying is not an easy thing, seeing children dying. But you know that you have done the best that you could have done. This child would have died irrespective, but you have done whatever was possible to be done to make that child comfortable, pain free, emotionally feel better, psychologically make the family feel better. You've done everything that you could have done. And palliative care kind of helps us just go to the limits, of the kind of care that you can give, which is something that I haven't seen in a lot of other fields in medicine. And that's what used to bring me back to the office every day, to the hospital every day, when I was working. So
because it's a matter of care. Now, palliative care, we say, is care beyond cure. So we are not looking, even though we are going to accompany all the children who can be cured and make the journey easier for them, but we care. And we care for the children and their families. We care for each other. And a smile for a child who has not smiled for days altogether is so rewarding. And laughter even better
for everybody who sees it.
Yes. So that's enough to ease the pain that each one of us may have had to shoulder alongside with the parents or with the child throughout the day. So that's why I feel that for me, children's palliative care is so much easier, because you have to play, you have to laugh, you have to get out of your way,
you have to be goofy, you have to be
to try to attract this. So that makes life much more.
It's a delight going on rounds. It's a delight. So I'm going to end by asking you this one question that we ask all our guests. What is living well? What does it mean to you?
Living well. So to me, it is doing at each moment what I should be doing, and I enjoying what I have to do. Is something that I feel that for me to live personally, knowing that I do my duty, but not as a duty, but when I enjoy doing that, then in terms of work, but it's also having a balanced life. So it's very important for me and for all of us in palliative care, that self-care. So having the balance with family life, with healthy living and sports and whatever relaxation, hobbies. So I think that is very important. You can't look after others unless you look after yourself. So also my personal spiritual life also is very important, so that I can have the strength to help others live well. And living well to me is not a self-centered thing, but it is really living for others. Is the way I see my life, and I have chosen my life. I'm really satisfied when I can do things for others and with others.
Wonderful. Thank you so much, Dr. Vero.
Thank you for inviting me
much for coming
and listening to me.
Thanks a lot.
Okay. I hope you liked it.